now it's my turn. Apart from being at ASHM, I'm also a person living with HIV. I've been living with HIV for 11 years. So today I'm just going to be talking about my journey with long-acting injectables. You've already heard about the clinical aspects and other aspects from other presenters, but my role here is to give you the lived and community perspective, what cabotegravir rilpivirine has meant in my personal journey living with HIV. Today, I'll cover my life before long-acting injectables, my experience in the ATLAS and ATLAS 2M trials, the benefits and downsides of being on this treatment for over 5 years, and what an injection day looks like for me. But I want to stress, just because it works for me doesn't mean that it's right for everybody. This story is grounded in the Australian context, which may differ significantly from New Zealand's. From my understanding, long-acting injectables won't be available here anytime soon, but I hope to give you a glimpse into what it's like for someone who wouldn't qualify under New Zealand's NIPA agreement, yet still benefits immensely from this treatment. Before long-acting injectables, I was on a carer's pension supporting my partner. My treatment was a boosted regimen, something that you don't actually have here at the moment. Cobicistat boosted elvitegravir, 3TC, lamivudine, and TAF. I never missed appointments, and my viral load was undetectable, most likely meaning that I wouldn't have been on a NIPA agreement to begin with. That hyper-focus on staying undetectable had a darker side. Sometimes I forget if I'd taken a pill already, so I'll take a second. This made me feel very unwell, made me nauseous, dizzy, kind of off balance. I'm not a doctor, but from moderating prescriber training, I'm fairly sure the booster was boosting all the other drugs in my system. When my GP told me about the ATLAS trial, they noted my pill anxiety and said that I might have access to 1 monthly injections if I were to take part. I joined eagerly, but it was randomized into the control arm, so I stayed on pills. Although disappointed, I knew my current treatment worked and will continue to keep me undetectable. I kept trying to avoid double dosing, but really nothing worked. About 18 months later, I joined the ATLAS 2M trial. Again, I was randomized to the control arm, but it still gave me access to the 1 monthly injectable, which was already shown to be non-inferior. So this is my first real taste of what injectables could offer. After initial blood tests, I began the 30-day oral lead-in, then switched to injections. Mine have definitely done ventrogluteal, the side of the hip ever since. My nurse has estimated about 70 of her patients do it ventro and 30 dorso. I've stuck with ventro because it's consistent for me and generally less awkward in a clinical setting. The common side effects started quickly, mainly soreness at the site. The right side always seemed to be a bit more painful. I also noticed fatigue. I napped right after the shot. Being unemployed at the time, that was fine. I also developed a small lump at the injection site, which was common with these types of medications. On rare occasions, I had a bit more of a severe reaction. When I was down in Melbourne, a few days after the cabotegravir injections, I felt a sharp pain going down my left leg. I couldn't put any weight on it. It happened a handful of times over the year, but since then, I haven't had an issue with it. The ATLAS 2M results showed that 2 monthly dosing was non-inferior. Then after about over 200 weeks in the study, I transitioned out into the 2 monthly schedule and formally exited the trial. Since then, I've stayed on cabotegravir as part of my regular care and it's still the treatment of choice today. Years later, I'm glad I made the switch. In fact, I had my most recent injections just 3 days ago before arriving to Auckland. Life's very different now compared to the trial days. I now work full-time at ASHM, and there's no midday naps. I'm also in a much healthier relationship. Injection day now has its own routine that fits my working life. I always book my injections for late afternoon, for example. Since I feel tired afterwards, it makes sense for me to go and do my workday first. On injection days, I go into the office and then take a bit of personal leave at the end. My most recent appointment was at 4:45 p.m., enough time to wrap up and head over calmly. At about 3:45, I took some paracetamol to help with the post-injection soreness. By 4 o'clock, I said my goodbyes, gathered some resources for this presentation and my trip to Auckland, and walked to the clinic. That short walk clears my head and feels like I'm shifting gears from my workday into my personal health time. I arrived early, checked in, and was called in right on time. My doctor has only given the injections to me once. All of the other times it had been the practice nurse. Since this was my first time with her, she asked how I preferred the injection, which side I wanted first. These small touches made this experience more personal and felt more respectful. By 5 o'clock, I was done with my next appointment booked into my calendar. No adverse reaction meant no need to wait around. In under 15 minutes, I was heading home, making a mental note to stop at the shop for dog food for Max, because life goes on, even on injection days. For me, the biggest benefit is the freedom of anxiety of daily pills. I'm no longer about having to miss a dose or accidentally taking 2. My quality of life has improved dramatically. I don't have to carry pills everywhere. I don't have to have that constant mental reminder that I'm managing HIV every single morning. I'm fortunate that I can also fit my injections into my schedule. I know there'll be lingering soreness and fatigue, so I plan appointments late in the day. My workplace respects my personal leave without demanding details. This flexibility works for me, but I know it's not realistic for everyone's job or lifestyle. I hope people living with HIV in New Zealand get access to injectables soon without solely relying on NIPA arrangements, because treatment choice matters. If this delivery method suits someone's life, it should be an equitable option priced at the same as tablets, so no one is excluded because cost or bureaucratic hurdles. Ultimately, this is about quality of life being shaped by people living with HIV, not just by treatment guidelines. Current antiretroviral therapy works well for many, but some may benefit from long-acting injectables. Others prefer tablets, and that is totally fine too. True equity means having both options available so each person can choose what's best for them. Thank you.